Hello, welcome to the first video lecture on the introduction to coding and reimbursement. In this video lecture, we're going to lay the groundwork for understanding the relationship between health terminology, classification systems, and HIM. We'll talk about medical nomenclature, coding resources, coding systems, and the critical use of coding systems and how they relate to reimbursement. Excuse me. We'll discuss the difference between large and small code sets and get into basically the foundation and the fundamental things that you'll need to know so you can understand the relationship of coding and reimbursement. Okay, and again, this is the introduction to coding and reimbursement. And third-party payers, physicians, nurse practitioners, PAs, everybody uses nomenclatures and classification systems to collect, store, and process data for a variety of purposes, one of which is reimbursement. So with reimbursement, we need to process, organize clinical data for patient care and basically use coding sets and nomenclature to organize it so we can reimburse providers for their services. The Centers for Medicare and Medicaid Services manages the implementation of the Medicare Prospective Payment System. Payment systems, fee schedules, and exclusions that use both ICD-10-CM for diagnosis coding, ICD-10-PCS for hospital-based procedures, and CPT as standard code sets. Normally, third-party payers adopt payment systems, fee schedules, and exclusions after Medicare has implemented them. Payers modify them to suit their needs. Hospitals submit UB4 claims to payers for inpatient ambulatory care encounters. Physicians submit CMS 1500 claim forms for payments for their services. When healthcare providers document patient care, they use medical nomenclature as described in Table 10.1. This is a vocabulary of clinical and medical terms. This is different than a coding or classification system. This organizes medical nomenclature according to similar conditions, diseases, procedures, and services, and has codes. Codes are basically alphanumeric strings or numeric strings, depending on the system, for each. These codes are reported to third-party payers for reimbursement. They're reported to external agencies for data collection and internally for education and research. Excuse me. The administrative simplification provisions of the Health Insurance Portability and Accountability Act of 1996, which we all know and love as HIPAA, required adoption of two types of code sets for encoding data elements, meaning the diagnosis codes or procedure codes. Medical nomenclature is covered in Table 10.1. Please pay attention to that. A lot of what we're going to talk about are the coding classification systems, right? When we say coding system or classification system, we're talking about the same thing. And you can see an example of that in 10-2. So when we talk about code sets for encoding data, we're talking about two broad types of code sets. The large code sets include race, diseases, injuries, impairments, other health related problems and their manifestations, the causes, the external causes of injuries, accidents, shootings, what have you, right? And then the actions taken to prevent, diagnose, treat, or manage said disease, said injury, impairment. The small code sets include race, ethnicity, type of facility, and type of unit. When we use the term third-party payer, we're talking about an insurance company. They process a claim for reimbursement that's covered by a health plan, right? Payers can serve as Medicare administrative contractors, formerly known as carriers or fiscal intermediaries, and they process Medicare claims for Part B and healthcare facilities, Part A, respectively. Third-party payers that are mentioned in Table 10-2 include Blue Cross Blue Shield, commercial insurance, and employer self-insurance plans. The government-sponsored programs, excuse me, such as Medicaid, Medicare, and TRICARE, managed care companies, and workman's comp, right? These are all payers. Disability insurance or disability income insurance replaces between 40 and 60% of an individual's gross income tax-free if an injury or illness prevents that individual from earning an income. Policies usually require a 90-day waiting period from the onset of a disability before an individual can apply for disability benefits, meaning the elimination period. Social Security disability insurance pays benefits to an individual and, under certain circumstances, family members if the individual's worked long enough and paid into Social Security. Supplemental Social Security pays additional benefits based on financial need. A term that you'll see again and again in healthcare is utilization management. Utilization management's goal is to manage healthcare costs by managing the patient or the client and the quality at the appropriate level of care. So what that involves is reviewing cases for appropriateness and medical necessity. We sometimes refer to this as pre-admission authorization. When a provider accepts a capitated payment, this is a predetermined payment for each subscriber for a specific period. Could be a month, could be a member. An example of this would be Medicare Part C and some of these other capitated plans. So it's not based on volume. It's basically you will take care of X amount of patients, and as a result, your medical group, medical practice, what have you, will get this amount of money for this time period. Managed care is being challenged by the growth of consumer-directed health plans. These define employer contributions and ask employees to be more responsible for both healthcare decisions and cost share. Most payers, except for prepaid or managed care plans, initially reimburse providers according to a fee for service, meaning it's a retrospective payment system that bills payers once services have been provided. So somebody goes into a medical office, they're seen, there's a code attached depending on what they were evaluated for, managed, and what procedures were provided. And then that code maps to a fee schedule, and the medical practice gets that. It's done retrospectively. Now the federal government's looking at prospective payment systems. So in other words, if somebody's admitted, they have a principal diagnosis of X, it just maps to this disease category. That's all the hospital will get. And we'll talk more about that shortly. Excuse me. And that's all I have for you. Come back for our next video lecture, and we're going to talk more about payers, something that everybody will be dealing with in our United States healthcare system. We'll see you then. Bye now.